This is presentation number 4 in the neurovascular imaging series, prepared by Prof. Sharaf and revised by Prof. Rami Edward. It will be on the value of CT in stroke. Highly CT and CTA, CT angiography in acute stroke are highly accurate in identification of the proximal segment of a large vessel at the circumvolus occlusions, and therefore in the rapid triage of patients to intra-arterial or intravenous thrombolytic therapy. Poor stroke outcome, that means if you find hyperdense MCA sign on early non-contrast CT, know that the main artery is occluded or about to occlude, and if the parenchymal density in the early stages is more than 50% of the middle cerebral artery territory, again this denotes a poor stroke outcome. So the CTA non-contrast is important to identify the proximal, to identify the infarct, and CTA sometimes will be resorted to if the main vessel is occluded. It will present as a dense vessel. A hyperdense middle cerebral artery is an indication on early non-contrast CT scan that this of poor outcome. Early parenchymal hyperdensity more than 50% of the territory is again denoting poor outcome. MRA will be important in triaging patients to intra-arterial or intravenous. CTA, to visualize acute clot in the MCA, distal internal carotid artery, basilar artery, and other major vessels at the circumvolus, and to better delineate potentially salvageable underperfused ischemic areas. This is a penumbra, so CTA is useful to see the vessel, useful to see the penumbra, and useful to see unsuspected region of vascular occlusion, perfusion deficits, other than the infarct in study. We need post-processing imaging reconstruction. We need the source image, which is very important, CTA-SI, that means the CT angiography source image. We want to do maximum intensity projections, MIP. We want to do multiplanar volume reformatting, curved reformatting, shaded surface display, and volume rendering. These are the image reconstruction you should know about. 6. Source image, maximum intensity projection, multiplanar volume reformatting, curved reformatting, shaded surface display, and volume rendering. Now here, this is on the left is the non-contrast CT scan, non-enhanced CT scan, and on the right is the CTA source image. Of course, the difference is very evident that the CTA source image shows a lesion underperfused very clearly. The same here. On the left side is the CT non-contrast, on the right side is the CTA source image, and this is the source image. It delineates very well the ischemic infarct, right cerebellum, brainstem, and left temporal region. Limited evaluation of the vertebral artery due to streak artifacts and poor choice of the scan time is common because, of course, the vertebral artery is at the root of the neck. There are streak artifacts, and it needs synchronization of the scan time with the passage of the bolus along the vertebral artery. So this is important. That's why the vertebral artery is usually limited. Usually is the study of the vertebral artery is limited. Don't forget that there are something called calcification of the valves, and the calcification of the valves is not a thrombus, it's not an aneurysm, it's not like this. This is the valves, this is the valves with calcific spot, and it can appear in angiography as like this, which should not be mistaken for an aneurysm. So don't, and these are the biennial and habenular calcifications. So don't forget that there are normal calcifications within the meninges, valves, biennial region, and so on, choroids. This is the maximum intensity projection, where the vessels containing contrast are brought into good image, high resolution, and this of course on the expense of the parenchyma. The parenchyma is not evident the same as vessels. This is maximum intensity projection, and we here have the circle volus, and this is the middle cerebral on each side, and this is anterior cerebral branches, and this is how the straight sinus fills from fen of Galen. And here is the basilar artery with its two branches, cerebrals, coming from two vertebrals and then branching into two cerebrals. Occlusion of the left carotid is seen here. If you look at the region of the cavernous sinus, there is no vessel here, and consequently the middle cerebral branches are not opacified, seen in the coronal and seen in the axial. In the axial, the same. This is the region of the cavernous sinus, it is empty, and the middle cerebral artery on the left side is no longer seen. But still we have some vessels here, and these are coming from collaterals. So collaterals can do. Here the vessels, here are the collaterals. MIP means that we are searching for the vessel and not for the parenchyma. Occlusion of the left common carotid and left middle cerebral, coronal and axial. CTA MIP images, maximum intensity projection images, different views. Occlusion of the right MCA M1 segment, which is a transverse segment. This one, it's occluded here, it's occluded here in the coronal and in the axial oblique. It is again not complete. The sylvian features are not, the sylvian branches are not opacified. M1 segment of the middle cerebral artery. That is the transverse segment of the middle cerebral artery. CTA SI, that means CTA source image and the curved reformatting of the left internal carotid artery. Now this is called the curved reformatting. This is the axial source images, and this is the curved reformatting, coronal and sagittal, showing that there is occlusion, definite occlusion of the left internal carotid artery. And here the ring sign of a thrombus inside is seen with the Miller flow around. This is CTA-SI with curved reformatted images. Curved reformatted, you follow the artery. Curved reformatted images means you follow the artery. subarachnoid hemorrhage, curved reformatting and axial MIP, and volume rendering. Confirmed the presence of aneurysm. This is curved reformatting. Curved reformatting, that means you are following the artery. This is the axial MIP. You can see clearly the aneurysm, and here is the volume rendering image showing the aneurysm. Here we have non-filling of the left middle cerebral, occluded left middle cerebral stem, right MCA aneurysm. This is a shaded surface display, showing the aneurysm here on the right side, shaded surface display. Now CTP. CTA, CTP, that means cerebral blood volume and cerebral blood flow and the mean transit time. This is what we call perfusion. CT perfusion. So CTA, CT perfusion should include 3 images, at least 2. Cerebral blood volume, cerebral blood flow, and the mean transit time. Now, this is a cerebral blood volume showing a small area here of low density. This is the cerebral blood flow showing the area is extending to involve most of the distribution of the middle cerebral. And here is the MTT, or the mean transit time. Still we have something in the distribution of the middle and posterior cortical branches of the sylvian on the left side. So, to study the CT perfusion or the CTP, we have to have cerebral blood volume image, cerebral blood flow image, and MTT, and at least these 2. And these 2 will show the difference between the core and the penumbra. So this area, the whole area, cortical area, is salvageable, while this is the core of the infarct, and MTT confirms the same process. This is the MIP, maximum intensity projection image of CTA, of computed tomography angiography, CT angiography, showing the left middle cerebral artery occluded along its transverse segment before giving the curve of the opercular branches. The to study the arterial input function, the AIF, we are using what we call time density curve. This is a time density curve, the change of density with time. How to do it? We have region of interest. We put the region of interest on an artery and on the superior sagittal sinus. That means a reference point. This is to avoid volume average due to the bone. And then we get the density, true density, without bone surrounding, as it is compared with this one, superior sagittal sinus. We get when the blood at arrival, and then the peak, and then the passage of contrast on time. This is the arrival, this is the peak, and this is the passage of contrast with time in the two sites, 1 and 2. This is for the artery, this is for the superior sagittal sinus, and that's why we can exclude the changes due to volume averaging and bone artifacts. This is called the arterial input function. Arterial input function. This is again one of the procedures getting used from the CT angiography. Now, if we compare the CT volume and the cerebral blood volume and cerebral blood flow and the MTT, we find that there is no change in the region affected. That means that the core has no penumbra. There is no tissue at risk. This part is infarct, and only this part which is infarct. And this is confirmed in non-contrast CT scan. On follow-up. This is follow-up CT scan, non-contrast. It shows the same area of infarcts. The MTT was not true. It overestimates the tissues at risk. So the best is to use these two, cerebral blood volume and cerebral blood flow, and not use the MTT, which is the related to timing, because sometimes it gives overestimation. What happened here is that there is similarity of the affected area. That means that there is no penumbra, only core, and this is confirmed by follow-up CT scan non-contrast after a while, showing the same region affected. The MTT was overestimating. Now, if the cerebral blood volume and cerebral blood flow, as in this case, cerebral blood volume and cerebral blood flow are matching, so there is no intervention, regardless the lesion size. Large cerebral blood volume but larger cerebral blood flow This is possible based on the time post-ictus, post-insult, and the size. If the change in, if there is difference in size, that the cerebral blood flow is large, you consider treatment possible based on the time and the size. Of course, we said that if it is larger than 50, if it is less than 30, it is useful. 30% of the middle cerebral artery territory. Now, the last possibility is a small blood volume with large flow, cerebral blood flow insult. This is the ideal candidate because it corresponds with less than 30% of the degree of the size of the territory of the middle cerebral. Less than 30%. Typically, this is a good candidate for intervention. And the same applies for MRI. Both the same, no penumbra, no intervention. Very large volume, very larger flow. This needs some discussion. Small volume and large flow indicates to intervention. Now, here we have middle cerebral artery, transverse segment, M1, and here we have this area in the CT non-contrast. Subtle insular and identiform changes. Yes, it lost the density here. That means vanishing basal ganglia sign, and the ribbon is attenuated, and the sylvian fissure is attenuated. That means the ribbon is swollen. So a swollen ribbon with vanishing basal ganglia sign, you cannot differentiate, and extends into the frontal region. This is the region affected. In CTA, we have definite occlusion of the middle cerebral M1 segment. In CTA, axial source images and CTP perfusion studies, volume, flow, and MTT, there is large ischemic penumbra here. So in this, the source image, definitely there is definite change in density here, slow. So not only the frontal and temporal, but also the region of the posterior parietal. Here also, and here is definite down here, involving the whole distribution of the middle cerebral, and this needs intervention because the region seen as a core is small, while involving the region of the lentiform and the frontoparietal region, while the penumbra seen in the source image and in the blood volume and the blood flow is very big, involving the whole frontoparietal and partly the temporal. So it is an extensive penumbra. This needs intervention. The core is small, while the affected part is very big. How to know the penumbra here? The penumbra is seen in the source image after contrast injection that starts to extend while here it is only confined to this region. So the difference between the non-contrast scan and the source image, and the difference between the volume and the flow, is also indicative of the penumbra. So how to know the penumbra? You have three. One, the CT without contrast with the CT with contrast. You will find that difference. And here there is extension of the infarct down, low density area down. So you start to see, and you know that there is some extension beyond this score. But the exact is to study the differences between cerebral blood volume and cerebral blood flow. You will find that in this one it is mainly at the distribution of the middle cerebral near to the sylvian, and here it's very extensive reaching posteriorly, and in the MTT this confirms the same. So we have small core and large penumbra. According to this criteria, you should do intervention. Disadvantage of CTP relative to MRP. Of course, there is limited scan coverage. There is risk and complication of the contrast. There is ionizing radiations, and there is a more complex posterior processing, post-processing. More complex processing. So you have ionizing radiation, iodinated contrast, and you have processing. This makes the MRP, the MR perfusion, more advantageous than the CT perfusion. Thank you.